Hello?
Good morning, everyone. Sorry for the delay. Long drive from Southern Maryland. I got 10:03, so I'd like to call the meeting to order. We do have a quorum present, and I believe Dr. Anderson's on the call for the morning session. Are you there, Jerry? Okay. Maybe he'll be joining us shortly. So thank everyone for being with us today. As you know, we've got a long day, so we'll go ahead and get started. We've got the minutes that were submitted for the September 29 meeting, so I'll entertain a motion for approval as submitted.
So moved.
Moved by Stephen. Is there a second?
I second.
Second by Barry. All those in favor, aye?
Aye.
Opposed? Thank you. Public comment. Christina?
Yes, thank you. We had 13 entities submit written comments that have been provided to the board and also posted to the website. We have 5 people today registered for oral public comment. I'm going to start with the in-person commenters, and then we will move on to our virtual commenters. Each commenter will have 1 minute and 30 seconds to speak. I will call on those that are attending in person first. Once I call on you, please state your name, the organization, agency, employer, or other entity with which you are affiliated, if any, or whether you are a consumer, and the agenda item that you would like to address, and then you can start your comment. Can I have Melody Hessen, Reverend Ken Phillips Jr., and Larry Zarzecki please come up to the table? We're going to have you speak consecutively, one after each other, and then we'll go on to the virtual commenters. So we will start with Ms. Hessen.
Hessian like session. That's okay. Yeah, I'm Reverend Melody Hessian. I'm here to speak on behalf of the Delaware, Maryland Synod of the Evangelical Lutheran Church in America. Thank you. And speaking to, okay. And in our synod, we have 130 congregations scattered all throughout Maryland. So our denomination calls upon leaders like you to promote policies that address the ways in which relentless rising healthcare costs end up leaving a growing number of people without adequate care. Drug corporations can make prescription drugs more affordable without harming research and development. They choose not to. We as Lutherans believe that although healthcare goods and services may be bought and sold, healthcare is above all an activity of caring that grows out of relationships of mutual responsibility, concern, and trust. And that cannot be reduced to a commodity. Healthcare resources are often rationed based on economy rather than need. So Jardiance and Farxiga are major cost drivers for both state and local governments. We thank you for also considering Ozempic on this panel, or on this board. And we hope that this board uses its authority to make these high-cost drugs more affordable for all Marylanders. Thanks.
And take it away. Yeah.
I'm sorry. Up next, we have, yes, Reverend Ken Phelps Jr., and please just state your name, your organization, and then we'll start the timer.
I'll do that. It is Ken Phelps Jr., and I represent the Episcopal Diocese of Maryland and the Episcopal Public Policy Network, which also incorporates the Diocese of Washington, including the counties of Montgomery, Prince George's, St. Mary's, and Charles. So a pretty fairly good-sized constituency. And I'd say that since before its inception, the Episcopal Diocese, like many of our ecumenical partners, have supported the creation of this board and support its work. And we're very grateful for what you've done since 2019, and also grateful for the drugs you are now considering, and we wish you Godspeed in doing this. The Church supports this because of our basic teaching that healthcare is a human right, and we believe it should be universal, should be accessible. I mean, Jesus gave this stuff away, and we have a tendency to just commodify everything. And there is a real crisis out there. I could tell you about my congregation itself. I had a phone call on the way to this hearing from someone who needed my assistance in paying for their prescription drug. So it's too often we are putting people in that situation where they have to decide what it is they're going to sacrifice so they can afford this drug, or perhaps just forego the drug because they cannot afford it. It's beyond their means. And it is a crisis, and we need to do everything we can, and this is a small step towards solving that. But please, Godspeed, because we need to get relief to all Marylanders.
Thank you. And then next, we have Mr. Larry Zarzecki.
Good morning, Board. My name's Larry Zarzecki, and I'm an advocate for all Marylanders. And I just wanted to say thank you to the Board for all that it's accomplished in preparation for making high-cost drugs more affordable for Marylanders. I originally testified in 2019 for the original PDAB law, as the $3,000 a month out-of-pocket cost was devastating to me. I strongly urge you to, as quickly as humanly possible, put upper payment level limits on what state and local governments pay for Jardiance and Farxiga. As you're aware, once you've done this, the clock starts ticking so that 1 year later, you can help all Marylanders, that's all Marylanders, afford their high-cost drugs. Now on Medicare, I'm protected by the Inflation Reduction Act measures. Please act now to help Marylanders that are where I was before Medicare. Remember, medication and prescription drugs truly don't work if we, the people, all of us, even those in the room, can't afford them. And I also appreciate your work that you're doing for people with diabetes, Ozempic, and all of the other drugs. Thank you so much for having me.
That concludes the in-person panel. We will move to our virtual panel. For those that just joined us online, you have 1 minute and 30 seconds to speak. Once I call on you, please state your name, the organization, agency, employer, or other entity in which you are affiliated, if any, or whether you're a consumer, and then please state the agenda item you would like to address. Up first, I have Ms. Denise Gilmore. Are you on the line?
Good morning. My name is Denise Gilmore, and I'm speaking on behalf of AFSCME Maryland Council 3. We represent 50,000 public service workers across Maryland and would like to commend this board for all the great work you've done since 2019 to make high-cost drugs more affordable for Marylanders. Every day, our members, state and local employees, work hard to keep Maryland running, and they deserve access to the medications that they need without facing impossible financial choices. The board's work to set upper payment limits on high-cost drugs like Jardiance and Farxiga is a critical step toward making prescription drugs more affordable for public employees and their families. We need you now to move quickly as you can, to make Farxiga and Jardiance more affordable for state and local governments. The high cost of these drugs squeeze government budgets and therefore our members and taxpayers. And as you know, we can only help Marylanders 1 year after you have done this. Drugs don't work if people can't afford them. Marylanders suffer every day because they cannot afford their critically needed medicines. So please do not make them wait any longer than absolutely necessary for the help only you can provide. This isn't about policy, it's about real people who are struggling to manage chronic conditions and keep up with rising costs. I'm proud to stand with our union and our coalition partners in pushing for solutions that put Marylanders first. We'll keep fighting to ensure that every worker, retiree, and family in our state can get the care they need at a price they can afford. Thank you for your work.
Thank you. Up next, we have Mr. George Huntley.
Thank you. Making sure I've lost the feed. Forgive me 1 second. Thank you very much. My name is George Huntley. I am the CEO of the Diabetes Patient Advocacy Coalition, and I appreciate the opportunity to speak and applaud the work that the Prescription Drug Affordability Board is doing. We would ask that you look at non-UPL solutions in addition to, as you're thinking about the UPL. This conversation today is all about UPL. Our concern is that UPLs will not actually lower the cost for a patient at the pharmacy counter. And our position is we need to lower the cost for the patient at the pharmacy counter and make sure that the pharmacy actually stocks the drug. Non-UPL solutions like passing rebates through at point of sale to participants, delinking the pharmacy benefit managers compensation from the list price of the drug. And if we set an upper payment limit, we risk a pharmacy not being reimbursed at their cost, which we have seen in the federal side of the most favored nation, some of the IRA negotiations. We have seen pharmacies stop stocking those drugs, and we urge you to make sure that does not happen to patients in Maryland. These unintended consequences are the things most at risk. And we urge you to consider these policies in addition to, or while you're looking at this, give them at least equal weight. Thank you for your time and the opportunity to speak.
Thank you. That concludes the public comment for today.
Great. Thank you all. Excuse me. Thanks, everybody, and thanks the 3 that are here in person as well as the 3 that were virtual. Next, we'll go into the part 4 of our meeting, which is the staff overview of the cost review study process and the policy review process. We'll have a presentation by Andy and I guess anyone else that's going to join in. And then after that, we'll go into closed session for the first drug as far as Ozempic. Correct?
I think we'll also have a presentation on Ozempic.
Oh, okay. Yep. So both at the same time?
Yes, I'll give my presentation Sorry, I have a public meeting or a public presentation. And then after that, for board discussion on confidential proprietary information, you can go into closed session.
Right.
Michelle, did you want to clarify anything? Is that correct?
Yes.
Okay. Okay.
Right.
Correct,
I
yeah.
thought you had a presentation. That's the bottom line, is that you
Yes.
do have a presentation.
Public presentation to start with, yes, thank you.
You can start, a lot of presentations. We're waiting with bated breath.
Great. So we'll start with our overview of the cost review study process. I'm going to keep this very quick. This is a presentation that the board and any previous listeners have heard probably a dozen times at this point. We just wanted to do some level setting for folks that may be joining for the first time. This would be, the PDF, thank you. Oh, and actually I can, yeah. We just want this. Sure. Just in case. Yeah. Okay, so. Yeah, we want the overview presentation first. That was Ozempic. Oh, it might not be in here. This might be a different deck. Is there a second?
If you had 90 seconds, your 90 seconds would be up.
Correct.
I'm just saying.
Is there a second PDF, Christina, do we know? I can give this verbally as well, and I plan on keeping this very quick. Okay, so I just want to do some brief level setting for folks that may be listening for the first time. So we have a cost review study process that we'll be going through today for both Ozempic and Trulicity. The result of that will be potentially a preliminary determination on if those drugs cause an affordability challenge. If the board moves forward with that process, then it moves into the policy review process. And the second session today, we'll be working through the policy review process for Farxiga and Jardiance. Just as a reminder, the key finding that the board would make in their preliminary determination is whether or not the use of a drug product has led or will lead to an affordability challenge to the state healthcare system or high out-of-pocket costs for patients, and whether that use that led to the affordability challenges or high out-of-pocket costs is consistent with FDA labeling or standard medical practice. So for this morning's session, our preliminary determination, I just wanted to note again that that is not a final determination and may be subject to revisions or modifications. And the next steps are, again, the draft report. So coming out of this session, we'll be doing a draft report where we summarize the information considered by the board in conducting the cost review study, the board's deliberation, the circumstances or indicia reflecting the affordability challenge, and the board's preliminary determination. And the public will be able to comment on that draft. If the board does make their preliminary determination, then we have our two separate processes that we do. First, the staff identifies the drivers of any circumstances that the board identifies. Then we get those for public comment, and then we also provide policy solutions for those circumstances. Those can include UPLs or non-UPL policies, upper payment limits or non-UPL upper payment limits, and each of those have a slightly different process. Today and again in this afternoon, you're going to see the probably third step on the upper payment limit process, where the board staff publishes a UPL framework, as we call it. If the board moves forward with that, then we publish a methodology. I'll go over that later this afternoon. That kind of puts the meat on the bones of the framework that the board approves. So in this morning, we're going to be going over Ozempic and Trulicity, which we'll move into right after this. We are asking the board to make their preliminary determination. And this, again, is to be based on the best available information and identify, excuse me. And then we move into our policy review process, which you've seen for Jardines of Arcega. So I guess with that, again, just level setting for today, this morning we'll go over both Ozempic and Trulicity for the dossiers that were made available to the board, and then we will then move into the upper payment limit frameworks for Farxiga and Jardiance this afternoon. So again, just some level setting. With that, I'm going to move into the Ozempic presentation today. So the purpose of today's presentation is to give a board a summary of the information that was available in the dossier. The board has received a number of different elements to the dossier, which I'll go over shortly. I will go through all of this public presentation now, and then I think the board can discuss any observations or findings based on this public information. Then the board can go into closed session to discuss any confidential proprietary information. And then after that, the board would make any preliminary determinations. I expect all those preliminary determinations would be made after the closed session. Though in the closed session, the board will make their preliminary determinations. We'll just kind of announce them after the closed session, and then any determinations based on public information you can then make in that second part. Does that all sound correct, Council?
So far.
Okay, great. So with that, all right, so this dossier was originally published in August of 2020. We received comments on September 4th, and the final version of the dossier was posted on November 4th. There were no, let's see. Okay, thank you. Okay, so we received 8 comments on the dossier, and 5 comments were provided by organizations, 2 comments were provided by manufacturers, and 1 was provided by a patient. And then they included a number of different themes. There were a lot of some recommended technical changes that we were able to accept. There were some key feedback on process and deadlines that have been a theme throughout a number of the comments that we've received. There was some comments on just general concerns on upper payment limits. There was also support for upper payment limits. There were considerations of plan design analysis. So that's one piece of feedback is to continue to build out our consideration of plan design. There was also a lot of discussion about how to better collect, or recommending that we prioritize collecting physician and patient input. We also received, there was a lot of discussion around manufacturer affordability initiatives. We were able to update one of the dossiers with some key information that was submitted by one of the comment letters, so that was helpful. A lot of comments just clarifying that therapeutic alternatives should not be considered as therapeutic interchangeability. So there are key differences between these different therapies. And then also we continue to receive a number of different policy recommendations. So those are always helpful for if we do move into that second half of the process, which is the policy review process. The staff were able to try to incorporate some of the technical changes. So there were some general formatting and copy editing. And then we did include a disclaimer explaining that which NDCs are included in the cost review study. And I'll go over that new disclaimer when we get to the NDCs that are approved. But those were the main changes that were incorporated for the Ozempic dossier. Here, this is going to look familiar. It's the same organization as the dossiers that you've already seen. So here's the general layout. I'm going to go through each of these sections at a very high level just to give board members the information. So this is also the board is also allowed to consider a number of different exhibits. So the board may consider Exhibit 1, which is pricing history. So the public has an unredacted file. The board has has a redacted file. The board has the unredacted version that just shows the general trends in pricing history over time across a number of different metrics. Exhibit 2 are the RFI submissions that are available to the board through a secure methodology, but are not available to the public. We have a redacted version of Exhibit 3, which is the pricing of therapeutic alternatives. Exhibit 4 is general utilization data for the therapeutic alternatives based on our medical claims database. In Exhibit 5, we have cost effectiveness, a summary of cost effectiveness analysis research and also comparative effectiveness research. And then we also always make sure to link all the comments that have been received to this date on each of these dossiers. So as I noted earlier, we did update our disclaimer on the different NDCs. So one comment that we get on all of the documents that we put out is that our list of NDCs is over-inclusive. And that's by design. The board will remember that you approve a list of NDCs, and when you select a drug, it's selected at the NDA level. So then we pull in all NDCs that are affiliated with that NDA. And while only a subset of these NDCs may be relevant or like have substantial clinical utilization, it's important for us to look across the data to make sure that we're not missing anything. So this is a almost overly comprehensive list of NDCs, and only a subset of those NDCs will actually show different utilization data and pricing data. And we also wanted to note, and this was flagged by a number of comment letters, is that not all the products on these NDC lists are sold commercially. So what's included in here also includes sample product NDCs, NDCs owned by repackagers and relabelers, and then NDCs that only contain the active ingredient. But again, our position is that it's important to have a comprehensive list for the cost review study part of it, and then any policy that you implement, you may then want to apply to specific NDCs depending on the circumstances of that NDC. So that was we did update that disclaimer just to flag that this is an overly comprehensive list of NDCs. Next, we have this summary of the clinical information. So this table generally shows the doses for each of the different indications. You can see that there's 3 different indications. One is for just general type 2 diabetes. Then there's one for reducing risk of cardiovascular events. And then finally, there's to reduce the risk of end-stage kidney disease and ESRD and cardiovascular death. So these 3 indications are often comorbid in patients that have these drugs. So this is just a quick summary of where it fits into the therapy. And this, again, looks across clinical guidelines, not just the indications. And based on all of the different clinical guidelines that we looked at, we can confirm that all utilization data that the board is making their decision on is based on pricing data that is consistent with FDA-approved labeling or standard medical practice. So that is has been confirmed by staff. Here's a summary of the disease burden of type 2 diabetes. So this is something the board has seen before, but I think at a very high level, this is a very important indication and disease state that has a lot of prevalence throughout Maryland and impacts many patients in Maryland. So it is a high priority for us and an opportunity for making a big improvement in Maryland. The next slide is, oops. Also just flagging that there is a lot of comorbidity with both of the other indications. So again, reducing cardiovascular risks, and then also reducing risk of end-stage renal disease and cardiovascular death. So again, just substantial overlap, and the fact that this has multiple indications gives it a very important place in therapy. The drug was originally approved in 2017 and then received its subsequent indication on January 16th in 2020. It was approved to reduce the risk of major adverse cardiovascular events in adults with type 2 diabetes and established cardiovascular disease. And then in January 2025, so this is a new indication, Ozempic was approved to reduce the risk of sustained eGFR decline, end-stage renal disease, and cardiovascular death in adults with type 2 diabetes and chronic kidney disease. This is probably one of the most of the drugs that the board has seen have not had any issues with shortage. this drug in particular does have a very kind of long history of shortage issues. Right now, Ozempic is not currently in shortage. However, semaglutide products were listed in the shortage list from March of 2022 through February of 2025. However, these shortages have since been resolved. This is just a list of the FDA resolved shortages. A couple things to note on these shortages is that staff was monitoring the shortage while it was ongoing. And we also sent a clarifying inquiry to the FDA and learned that the FDA routinely places all products within the same active ingredient and dosage form on the shortage list. So in the case of the semaglutide shortage, the FDA placed both the brand name Ozempic and other products with such as Wegovy on the shortage list. So at the time that the shortage was active, the FDA published documents noting whether particular NDCs were available during the shortage while the shortage was active. So we do have copies of all those different documents starting in April 2024 that reflected in the table below. And again, this shortage has since been resolved, so it shouldn't have any implications for the board's decision-making at this time. Here's just a list of the patents. So this gives general market context to the board on timelines and different kind of plans on how the different patents are used around Ozempic. And then we get into some of the utilization of the drug product under review. So as you'll remember, we break our utilization into commercial. So this is the total gross spend for commercial in 2023, as well as the patient counts. We also break it into state and local government, which may be of interest to the board. And again, this is 2023 data. And then Medicaid data we also include, which is 2022 data. And then Medicare data. Also, so this is again, gross spend, patient counts, and then Medicare percentage of total gross spend.
So Andy, will the 24 data be available first quarter of 26?
It's available now. This is actually something we can talk about. We plan to talk through improvements to this process moving forward. And basically, what's important for the board to do is pick a set time that we cut off the analyses. And in this case, it was in August of 2024, I believe. In the future, we want it to be within a single cycle. So, we get the data. So data generally becomes available in the fall of a year that represents maybe 2 years before. So I would say that 24 should be available as of September of this year, would be my guess. So then we would just have that cycle that you're seeing the most recent data available in your dossier. At this point, we're basing it based on when the analyses were done. So next, we wanted to go through just the change in spend across years. So this compares the two most recent years, so that's 22 to 23. And you can see increases in certain NDCs, actually across all NDCs, is that correct? Yeah. But there you can see transitions to different NDCs and changes in utilization across NDCs. And this is represented across both. So again, we start with the commercial space, state and local government, and then also Medicaid, and then Medicare. For 4.3, this is the impact of utilization and spending on public budgets in comparison of the spending on prescription drugs to relevant benchmarks. Similar to the other analyses that we did in this cycle of cost reviews, staff was unable to assess the impact on public budgets for specific local governments. In the future, however, the cost review study, the staff will continue to work with state and local governments and other public budgets to identify standardized data to support this analysis and develop other methods of conducting this analysis. So I think there is a lot of opportunity to do some specific analyses in this space, but it was not available based on the data that we had at this time. Section 5 gets into different pricing information and rebates. So just as a reminder, WAC and AWP are available to the board, but are not available to the public. But here is the table of NADAC, the state, so national drug acquisition, national actual drug acquisition cost, the state actual acquisition cost, and the federal supply schedule. I think these are, again, generally representative.
Excuse me, I have a question.
Yeah.
Probably just me, but go back to 4.2.
Yep.
And so are there more than one 4.2 there are right now?
Yeah, there are. So there's going to
Okay,
be
so the very first one,
10A, probably. There's a table.
so is it just because the change in size where the gross spend went down?
Yeah, this seems to be a change in utilization of a specific NDC, so it probably moved over from one dosage amount to another. So it might have been them phasing out one dosage amount and moving to another.
Okay,
I
because
can
it's
confirm
kind
for
of unusual on our tables to see.
Yeah, that is a true, yes,
Okay, thanks.
true observation. Yeah. So scrolling down to, yeah, thank you. Yep. So these, again, are the different pricing metrics. So these are the publicly available pricing metrics. I think there's redacted tables in the dossier and an unredacted version for the board members. And then this is also available, I think, in the pricing charts that are available in Exhibit 1. In 5.2, again, this is confidential proprietary information, but we are able to estimate net prices and net sales based on different databases that we have access to. And that is available to the board. For 5.3, information estimating manufacturer net price and net sales, we did just want to note that the Ozempic was selected as a drug for the Medicare price negotiation program. The price has not yet been announced, so I think it's scheduled to be announced this month. And that would go into effect in January 1, 2027. So just wanted to note that that's a public data point that may be available to the board at a later point. For the average price concessions, discounts, and rebates that the manufacturer is expected to provide to the prescription drug product, those are included in the request for information. So those are available to the board, but not to the public as exhibits in the dossier. Same thing for the information supplied by the manufacturer on the relationship between pricing the prescription drug product and the cost of development and therapeutic benefit of the prescription drug product. Section 6 goes into the therapeutic alternatives, including the cost comparisons and the health economics outcomes and research. So these, again, are generally provided. Okay, so for 6.1, we go through the different pricing metrics of each of the different therapeutic alternatives. Those are available in Exhibit 3. Again, there's two metrics that are not publicly available but are available to the board. Those are the wholesale acquisition cost and the average wholesale price. But we do include each of the publicly available ones, the NADAC, the average acquisition cost, ASP when relevant, and then also the federal supply schedule. At 6.3, that's all included in Exhibit 4. So this is the utilization costs and out-of-pocket costs for the therapeutic alternatives. I'll just, again, note that a recurring theme that we've received is that our therapeutic alternatives list is a very broad list. Again, that was by design. But goes across a number of different classes and should not be considered interchangeable. It's merely just a list of therapeutic alternatives that can be considered at the same stage of therapy as the drug under study. For factors 6A, 6.4, this is the summary of the incremental costs associated with prescription drug product, including financial impacts to health, medical, or social services, as can be quantified and compared to baseline effects of existing therapies. And you can look to Exhibit 5A for a summary of the evidence on the cost effectiveness. I think at a very high level, the overall results favored Ozempic compared to Trulicity and other therapeutic alternatives. And then when Ozempic was compared to Mounjaro, the results were neutral or favored Mounjaro. So that's just a high-level summary of some of the key findings of that work. And the, yeah.
Actually, maybe more of a comment. So when we're summarizing the CER and the cost effectiveness analysis information,
Yep.
I think we do a better job confirming the data source with the comparative effectiveness, and they're usually trials, so that's been very helpful to see. With the CEA work, because it can be real-world data, so claims and so on, or trial data, or modeling studies and direct treatment comparisons, to the extent we're trying to figure out if there's even evidence available that could be customized for Maryland, which is then is more realistic if it's claims and so on. It would be helpful if that's also part of our summary in that Excel file, to be able to identify the source of data, whether it's modeling or claims trial.
We can certainly add that
But
as
thank you. This
qualifier
is
in there,
very
yeah.
helpful.
Okay, thank you. Yes. Okay, thank you. So that'll be available, and we can also verbally provide those to board members if necessary for this round. But future summaries can include that information. Thank you. In 6.5, we go over the comparative effectiveness. The summary of the comparative effectiveness research. So again, just at a high level, the choice of anti-hypoglycemic agents for type 2 diabetes is driven by a combination of different patient-centered factors, including the degree of lowering desired cardiorenal protection, side effects, and administration preferences. So that's oral versus subcutaneous, and then also cost. So clinically, all the anti-hyperglycemic agents are considered efficacious for lowering A1C and controlling blood glucose, though the absolute degree may vary between medication and class. Just to note, Ozempic and other GLP-1s are considered available as first-line therapies for patients. And again, it's a clinical decision between the patient and their clinician on whether or not this is the appropriate starting therapy for patients. In factor 6.8, we go over whether or not the prescription drug, how many generic manufacturers there are. In this case, there are no generics for Ozempic at this time. 6.7, there's no therapeutically equivalent drug products approved by the FDA. So therapeutically equivalent is a term of art that basically references direct therapeutic interchange. So generics or biosimilars. So at this point, there are no therapeutically equivalent drugs approved by the FDA under other applications. Going into section 7, the estimated impact on patient access resulting in the cost of the drug relative to insurance benefit design. So our analyses suggest that while there are statistically significant relationships between average copays and coinsurance, the number of and the prescriptions people use in a year, any impact that we were able to view in the data is small. So we did, again, literature review, and this is sources that go across the different classes that we reviewed so far. One study found that as patient copay levels increased from low, which was $10, up to less than $10, to medium, which was $10 to $50, and high, which is greater than $50, the proportion of patients with high prescription coverage decreased from 72% to 60% to 66% to 60%. So just as you can see, there is a linear, well, not linear, but a trend between the high cost of the drug and whether or not the number of days covered, i.e. they were filling the drug less. Yeah. Yeah, that was very confusing. I'm sorry. Yeah.
So, the direction of association is there, but I just wanted to clarify that last phrase, without controlling for other factors, that in fact, this is a correlation, no adjustment for any other potentially confounding factors.
Yes, that's my read of the study.
It was
yes.
like descriptive.
It's descriptive, yeah. So I'd have to take a closer look at the paper, and we can go to, staff can reconvene on this. But I think our takeaway from the paper is basically that there is a correlation between, if it's less than $10, the percentage of days supply, or the people that filled their drug more than 80% is higher than when it's 10 to 50 and then over 50. And it makes sense, but to your point,
Yeah.
there can be confounding factors that need to be accounted
And
for.
that's why I want to understand how much weight to put on this, is to what extent they control for other factors.
Okay.
So that, but it's helpful to
Yeah.
have this summary.
Staff will see if we can provide additional information on that study. There was a study that was specific to GLP-1 therapies, and it basically found that compared to patients with the lowest out-of-pocket costs, which that was $0 to $21, and those with the highest out-of-pocket costs, the ones with the highest out-of-pocket costs had a 1.25 times the odds of non-adherence, i.e. the higher the cost, the higher the likelihood that they would not adhere to the drug. Again, this is all just generally based on literature reviews at this time. We were not able to do anything within our data. Go ahead. For factor 7.2, the current or expected dollar value of drug-specific patient access programs that are supported by the manufacturer or drug product under review and the policies surrounding and implementing the programs. Staff identified 2 patient access programs for Ozempic. The first is the Ozempic Savings Card. This can allow patients to pay as little as $25, subject to a maximum savings of $100 per month for a 1-month prescription, or $200 per 2-month prescription, and then $300 for a 3-month prescription. The second program is the Novo Nordisk Patient Assistance Program. A reasonable search failed to disclose publicly available information concerning the dollar value of the Ozempic Patient Assistance Program, the Patient Access Program. In factor 7.3, we go over the average patient copay share and cost sharing for prescription drugs in the state. We do this for the commercial sector, so this is 19A. So we show the average cost share. We show the average deductible, the average copay, average coinsurance, and then average other member liability. We do that for both the, oops. So we do this for, excuse me, I'm getting my slides mixed up. Yeah, there we go, thank you. So we do this for commercial, the state and local government, and then we also calculate the average cost share, which is a term of art in our legislation. So we, in our dossier, actually include the actual equation, and we do that for the state and local government, I believe, is what we included here. Oh, we do it across all 3. You can see the commercial, you can see the local, state and local government, and then Medicare.
So Andy,
So
sorry for being late.
Yeah.
I had a meeting at Hopkins that I couldn't get out of, but I was listening to it on the way in. So thank you, and thank everybody for testifying. My question, and you might have covered it when I was trying to get into the building, but does the state cover Ozempic for weight loss?
Off the top of my head, it does not cover it for weight loss. It does cover for diabetes, but I would have to double check. I don't want to answer definitively.
So if the state employee was taking it for weight loss as opposed to diabetes or something like that, they would have to pay the full price in most cases? And so, and that wouldn't show up in your cost sharing if they were paying it directly, correct?
I think that is true. So our cost review study is focused on the indications approved for FDA labeling, and right now, weight loss is a positive side effect for the indications that are available, and then has it as a primary indication for other formulations. But I would say that that is correct, that if it is prescribed for not one of the FDA labeled indications, then it would likely not be covered by insurance, and they would have to pay out of pocket. So that would not be included in the data.
So
yes.
in that case, the state employees would have to pay a significant amount of money.
That is correct.
Okay.
Yes.
Thank you.
Yep. All right. So we went through average cost share. In factor 7.5, we include the mean, median, and 90th percentile out-of-pocket costs for patients compared to state incomes. So you can see that here. And then finally, in 7.6, well, not finally, in 7.6, we do an assessment of the impact of the prescription drug products cost to access by priority populations and the impact on equity. Again, this is specific research that we've done. We did a literature review. And then also, so we started with a claims data review where we were not able to make a conclusive assessment, though I think the dossier itself outlines the study that we tried to do and then also the findings that we had. But again, not able to make a conclusive assessment. So then we provide additional literature review. So just some key findings from the literature review is that female patients had consistently higher utilization odds ratios compared to males. Also, Asian, Black, and Hispanic patients were found to have consistently lower odds of GLP-1 use compared to white patients. And then higher medium household incomes were associated with higher utilization compared to low income groups. And then regarding initiation, Asian, Black, and Hispanic Medicare patients were all associated with lower odds of initiating GLP-1 therapies compared to white patients. And then patients with the highest income bracket were more likely to initiate GLP-1s, while the lowest income brackets were less likely. So all kind of interesting findings based on the literature. Again, primarily likely causative with, or correlations, and we'd have to dive in more for the causation, but I think they are relevant observations.
But what you would say is that access to low-income individuals is less than individuals of high income. So there is
No,
Utilization is less.
utilization is less, not access.
As opposed to high income.
That, yes, utilization is less. The reason for that, I think, is that I can't, it isn't defined by literature,
But
yeah.
I mean, the fact is that there's less utilization for
Yes.
low-income individuals.
That's correct.
Which is not necessarily a bad thing.
Well, I mean, if I want access to the pharmaceutical.
Well, but that's not the determination whether they had, if it was accessibility or not, right?
Well, essentially, what I'm reading is that they have lower utilization rates.
Right.
And
But again, it comes down to price. You know, if people have lower incomes, they're not going to have the expendable money to pay for something that may or may not be covered.
Right.
Yeah, it's called social determinants of health.
Andy, back in like 7.3 to whatever,
Yep.
7.3. When you're when you're combining the state and local, I just want to understand.
Yeah.
Who's gathering the local for you?
It's
It
all,
isn't DBM, right?
no, it's part of the all-payer claims database
Oh, okay.
data. So this is one of the things that we will continue to refine over time. So right now, when you go into the all-payer claims database, one of the things that it asks for is who the insurer is and like what book of business it is. And there's a flag that we use when we're doing our analysis that represents state and local government. It's a flag that exists in the data. I think we're relying on the accuracy of that flag as it is, and then trying to supplement with additional information. But it's, again, the way that it's collected for the all-payer claims database is actually probably better than anything we would be able to do in terms of comprehensive submissions. But then we are also trying to separately gather additional information specifically from the state and local governments.
And I haven't talked to you about this in a while. So the data we asked you to work with DBM for the employee and retiree system a couple years ago, how does that, have you gotten that data from them, and how does that compare to all claims data?
It's It's in this data set, so it's a subset of the data that is represented here. But I think we probably could parse it out, like we could do separate analyses on that based on the all-payer claims database, but then we also separately go to DBM. It's probably not represented in this information, so I don't think there, or in the dossier, so I'm not sure there's any specific determinations we can make for like state employees and retirees based on the data that we've done our analysis on. But I think in additional work that we do for things like policy review and things like that, those could become available to you. So, yeah.
Okay, thanks.
Yeah. And part of it is still us just becoming more familiar with the all-payer claims database as well. So this at a very high level, we can say does capture all state and local government spending. Once you start to stratify it, it gets will evolve over time.
On the 7.6, before we moved on, Andy, was you mentioned what, I guess, anchored the lit review for the staff was the AHRQ priority population definitions.
Yeah.
And I wondered to what extent there was coverage of all the facets. So certainly demographics is one. Race, ethnicity, we know is difficult with a lot of private payer claims data. APCD sounds like it's no exception. But there are also sort of rural, urban. There's women, our priority population, special healthcare needs, individuals with disability, multimorbidity. To what extent is that possible with the ABCD, or is that something that the staff is still exploring?
It's something we're still exploring. So we can give you the indicator. So we can, I'll have to look specifically at the analysis that we did, but there are elements of some of those indicators within the all-payer claims database. And we did try to do some analysis on the all-payer claims data. What the second portion is just a literature review. So we, and actually, yeah, we have an analysis. I think it's within the dossier methodology on this specific analysis. But it basically says what's available in the all-payer claims database and then what we can use it for. It's a very small subset of the HRQ definition of priority populations. But then we just did a literature review specific to the drug. So I think the main limitations there were just available literature. So we kind of did the research at the drug level and then took any kind of disparities research or anything there or impact on priority populations. It was just based on available literature, and we were kind of limited to whatever data elements they were looking at.
Yeah, okay. No, and that's understood. I think for me, what would be clearer too is the process side of here are the AHRQ domains, here are the ones we map to, whether it's APCD or lit review, like here are the keywords we used.
Yeah.
I imagine that there are studies that have looked at rural-urban differences in terms of access and outcomes, but where that overlaps with our particular use case, it's something we can determine. So I think that would be helpful. And then just for the report itself, the reporting here of the odds ratios is very helpful, but it's missing the bounds, the confidence intervals around them. And I think that's just as helpful as having the effect estimate itself across these studies, because a lot of these estimates seem quite close.
Okay. Yeah, we can try to pull that in. So we can also take a look at the papers and try to get those to you as well. Staff can take a look at that. I think just at a high level, okay.
All right, you want to kind of wrap up this section?
Yeah. Okay, so noted on the changes, and those are certainly changes we can make moving forward. And then if there's specific questions you want to address for this cost review study, we can look those up. Staff can look those up while we're speaking. Okay, so then for 7.7, we have the cost to the healthcare plan based on patient access consistent with FDA labeled indications. So we did calculate, we basically looked at the units with the range for the number of units that are used under FDA labeled indications or medical practice, and then apply the WAC unit price, and that is provided to the board. So what the cost would be if it was just paid at the WAC level. And then Section 8, this just goes over the comments that have been available to the board. We received initial comments during the following comment, so we had our initial 60-day comment period. We had a limited response. I think one thing that we've heard both from from the board and the public is trying to get more specific input from patients and potentially clinicians. And that was specifically why we went through the second comment period, which was posted on 10/28 of 2024, and we actually did specific outreach to different prescriber groups and also patient groups. Still limited response, so that's something that we'll continue to try to improve over time, but that was a priority for us and why we opened up that second comment period. And then also we asked for written comment on the draft dossier, which was posted on August of 2025, August 20th. So that is also, all those comments are available to the board. And our final slide, so that takes us, yeah.
That I wanted to commend the staff on that second comment period that was opened up, because as you mentioned, this is something that we're continuing to be interested in. So the effort that's being made to allow for time for individuals to provide input, I think hopefully something that people appreciate. It's something that certainly is a change from our prior process and great to see.
Great, thank you. For 8.2, analysis of the impact on state and federal regulatory compliance issues related to the prescription of our product. We did not identify any other regulatory or compliance issues that provide additional context of the market related to this prescription drug. For 8.3, input from state and local government entities that we continue to work with our state partners. At this time, we did not receive additional input from state and local government related to our cost review of Ozempic, but we do expect that line of communication to continue to increase over time and expect that information to be available in future studies. And then finally, in factor 8.4, information analysis submitted by an entity. The documents that we received in response to the request for information are available to the board, but not to the public. Staff did redact information that might be considered a second step from submitting the submitted documents from the board as exhibits in the dossier. So, sorry, there's a subset of elements that are only available to the board if you are not able to make your determination based on the data that's available to you now. Those are the only things that have been redacted in the information that are provided to the board. So if the board is not able to make a determination on the available information, there may be certain additional data elements submitted in the RFI that we would make available to the board for your consideration. So with that, I would like to just open it up for any comments or questions, and if the board wants to discuss or deliberate on any of the findings from the publicly available information at this time, you're welcome to do so.
Great, thank you very much, Andy. Does anybody have any comments before we go into closed session? We would certainly welcome them. Jerry?
No, I think we asked them while they were going, so I'm fine.
You have anything, Barry?
Nothing, no questions for me at this time.
Stephen, you've been quiet this morning. All right. With that, I'll entertain a motion to close for the closed session, review and discuss proprietary trade secret and confidentiality information concerning Ozempic under general provisions 3-305B13 and Health General Article 21(2C)(03) and 21(2C)(10). Is there a motion?
So moved.
Motion by Jerry. Is there a second? Second by Stephen. Any questions? All those in favor? Aye.
Aye.
Opposed? No? Ayes have it. Thank you. So we will go into closed session now across the street or across the hall. For those of you here, read a good book. We'll be back shortly. And for those of you online, just kind of do whatever you can do. Okay, sorry, everybody out there, but we're back. And we're going to wrap up with the Ozempic, and then we're going to go right into the second drug, which is Trulicity, which Andy will give a quick presentation on that. Then the board will go back into closed session for that, and we'll eat lunch while we're in closed session doing that work. So let me open it up to the board members for any additional thing before I ask for a motion to ratify what we did in closed session.
I
Barry?
had a comment, thank you. This is with regards to the utilization data and section 4.1, where it was broken out. Andy went over this, broken out by commercial, state and local government, Medicaid and Medicare data. And summing up those percentages in that rightmost column, where it talked about percent of total gross spend by NDC, coming up with an overall percentage value. For state and local government was 4.87%. And I was comparing that to the commercial and Medicare. So that 4.87% stood out because Medicare summed to 1.9%, commercial 4.45%. And as we've seen with Medicaid, lower, but those were the two numbers that I calculated, but the state and local government proportion seemed high at 4.87%, approximately 5% of utilization of total gross spend, I should say.
Okay. So that's something you'd like to add?
Yes.
Okay. What was the rebate percentage of that? Do you remember?
Can't say. Can't say.
Oh, that's right. Sorry. Bad question by the chair.
No,
That we wanna
aside from
add?
what we said in private session.
Correct.
Barry, I just want to make sure I'm capturing so the total spending for Ozempic for state and local governments exceeds, you said 4.87%. Is that right?
Right, so it represents 4.87% of total gross spend for state and local government.
Got it. Thank you.
Okay. Hearing nothing else, I'll entertain a motion for us to adopt.
I'm sorry. Are you saying that that's a circumstance?
Yes.
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 Representing an affordability challenge for the state
So
and local
again, I'll
government.
move to adopt what was discussed and taken up in closed session and voted on, and then also to add Barry's state spend.
May, from a procedural perspective, may I suggest that you adopt, take action on a Barry's motion, and then direct me to include that in your resolution and adopt the resolution ratifying what you did in closed session?
It's the reason why I never went to law school. Certainly. Let me withdraw the motion and let me ask for a motion for a Barry's motion or comment.
So moved.
Moved by Stephen, second by Jerry. Any discussion on a Barry's 4.87% cost of state spend? Hearing none. All those in favor, aye?
Aye.
Opposed? Great, thank you very much. Now I'll entertain an adoption of what we just moved in public, as long as also the private. Unless council has anything else, I'll entertain a motion for.
Do you want to do it as a resolution, because we have a resolution adopting it, or you're just going to ratify what was done in closed session first, or?
Whatever council wants.
Council would suggest
I think we
that
did resolution last time, so we'll do resolution again.
Resolution 2025-03 of the Prescription Drug Affordability Board Preliminary Determination Cost Review of Ozempic, November 17th, 2025. Whereas the Prescription Drug Affordability Board is authorized to conduct a cost review study of the selected prescription drug products, and whereas the board selected Ozempic for study, and whereas the board has considered the data, analyses, and information assembled by staff in the dossier organized in part by regulatory factor, And whereas the board has considered the public oral and written comments received to date as part of the cost review process, and whereas the board considered, discussed, and deliberated concerning the proprietary, trade secret, and confidential information and data in closed session, and whereas the board may preliminarily determine whether use of the prescription drug product has led to an affordability challenge to the state healthcare system or high out-of-pocket costs for patients, and whereas the board may identify circumstances under which the prescription drug product has or will lead to an affordability challenge to the state healthcare system or high out-of-pocket costs to patients, and whereas upon consideration and deliberation of the proprietary, trade secret, and confidential information in closed session, the board voted to make a preliminary determination and identified one circumstance relying on confidential proprietary data under which the prescription drug product has led to an affordability challenge. And whereas the board hereby ratifies the closed session vote determination and the identified circumstance as set forth below, along with the determination made in open session. It is hereby resolved that the board makes a preliminary determination that use of Ozempic has created an affordability challenge for the state healthcare system and an affordability challenge in the form of high out-of-pocket costs to patients, and that the use creating the affordability challenge was consistent with the labeling approved by the FDA or standard medical practice. The circumstances under which the prescription drug product has led to an affordability challenge include at 90th percentile patient out-of-pocket costs to the state and local government markets is disproportionate to the net cost paid by payors, done in the closed session, and total gross spending for Ozempic for state and local governments exceeds 4.87% of gross prescription drug spending for state and local governments in the public session. Be it further resolved that in accordance with Comar 14010405F2, the board's preliminary determination is non-final and subject to revision and modification, and any circumstance is a sufficient and independent basis for the preliminary affordability challenge determination. Be it further resolved that the executive director and staff are authorized, directed, and empowered to draft a cost review study report in accordance with this resolution and the regulations to be published as a draft for public comment, subject to a final determination and approval of a final report.
Great, thank you. So, moved by Stephen, second by Barry. Any discussion? All those in favor, aye.
Aye.
Opposed? Unanimously aye. Andrew, you're up. Trulicity, please.
All right. Well, thank you to the board members for that discussion and deliberation. Next, we're going to go into the Trulicity cost review study. The dossier was posted on August 20th and comments received on September 4th. And then we did post the final version on November 4th, for which you've received comments in this meeting. Similarly, as above, we had different feedback on technical changes, process, upper payment limit concerns, and other items listed below. We did update the disclaimer about including additional NDCs, and I'll go over that in just a moment. And again, this dossier follows the same structure. We have the 8 different sections that I'll provide an overview, and also the attached exhibits that are available to supplement the dossier document. So with Trulicity, I think one thing to note is you'll see that this NDC list is much longer. And one thing that was flagged in some of the comment letters that came in was, again, that some of these products are discontinued and not sold commercially. So we did update the disclaimer as mentioned. About 6 of these NDCs are the active NDCs that are most relevant for analysis, and you'll see those throughout the dossier. But we do have a total of 22 NDCs here. As part of this research, so just for your reference, we do go through something called RxNorm, which is a national database that is supposed to capture all NDCs that are affiliated with the NDA application. We did want to note one element that upon our research, we identified about 7 NDCs that were not included in the original list of approved NDCs by the board. So I am going to ask for a motion at the end of this presentation to approve the additional 7 NDCs that are in the dossier to be included in the list for for consideration for the cost review study. And their inclusion is explained in the footnote. It doesn't have a substantive change, but for the purpose of completeness, we do want to include all of those NDCs. So just going through the presentation itself. So clinical information, again, this is it has 2 indications for improving glycemic control and then also to reduce major adverse cardiovascular events in adults with type 2 diabetes that have been established, have established cardiovascular disease and cardiovascular risk factors. Again, confirming that all pricing and spending data is consistent with the FDA labeling. So we did review, here's its place in therapy. GLP-1s are considered first-line therapy, balanced with a number of patient and prescriber considerations. As discussed earlier, diabetes and the comorbidities of cardiovascular disease are quite prevalent and quite impactful. So this does have an important place in treating patients in Maryland. Yeah, so obviously a very important disease state and meets the board's needs to, for consideration. Okay, so going to the regulatory approval, it was approved in 2014. And then it was approved for use with combination for basal insulin in 2017. In 2020, it was approved to reduce major adverse cardiovascular events, and then also received an approval for additional dosages for treatment of type 2 diabetes. And then in 2022, it received approval for use in children older than 10 with type 2 diabetes. So that's the history of its indications. The drug is not currently in shortage. Duaglutide was listed in shortage from 22 to 2025, but these shortages have since been resolved. So you can see the additional shortage list here. And then here's the list of patents and the history and timing of the patents, just for the board's reference. In terms of utilization, same as before, we provide the total gross spending in the state for different groups. So this is the commercial population. We provide it for state and local government, as well as Medicare, and then also Medicaid. That was Medicaid, and this is Medicare. So you can see the use over time and the specific gross spend on this drug. If we move on to 4.3, staff was unable to assess the impact on public budgets, but again, this is something we hope to kind of refine over time. For the pricing information and rebates, again, AWP and WAC are available to the board, but not the public. But here's the list of the different publicly available prices, NADAC, actual acquisition cost, ASP, and the federal supply schedule. Board was also provided with the net price and net sales that are redacted as proprietary information. Trulicity was not selected as one of the drugs for the Medicare price negotiation program, so we would not expect that as a publicly available price at any time. The board had access to Exhibit 2, which is the RFI response documents, and they are available to the board, but are not available in to the public, and that's what addresses the average price concessions, discounts, and rebates from the manufacturer is expected to provide. Same thing for 5.5, information by the manufacturer on relationship between pricing and cost of development and therapeutic benefit. Those were all supplied through the request for information. In terms of therapeutic alternatives, so WAC and AWP were redacted, but we do have publicly posted Exhibit 3, which is the cost of the different therapeutic alternatives. And then also the price concessions and discounts are available to the board in the redacted version of that document. Finally, Exhibit 4 goes through the different utilization costs and out-of-pocket costs for different therapeutic alternatives, so that's available to the board for their reference. In 6.4, we pulled the studies on incremental costs associated with the prescription drug product, including financial impacts to health, medical or social services that can be quantified or compared. And in the general findings is that the result of all 4 of the studies that included Trulicity favored other drugs, primarily Ozempic or Rybelsus, over Trulicity. And Ozempic or Rybelsus cost was set either equal to or less than Trulicity, achieving higher proportions of target clinical outcomes. So analysis outcomes favored those as more cost-effective options. In factors 6.5, overall, the choice of anti-hyperglycemic agents utilized for the control of type 2 diabetes is driven by a combination of patient-centered factors, including the target HbA1c that need, or the lowering, the lowering targets, as well as cardiorenal protection, side effects, and administration preferences and cost. Clinically, all anti-hypoglycemics are considered efficacious for lowering HbA1c and controlling blood glucose. And again, GLP-1s are considered a first-line therapy, so that's between the patient and their clinicians to select that. There is not currently a generic for Trulicity, and there is not an applicable biologic product because the therapeutic equivalence is a concept reserved for small molecule drugs associated with the FDA's Orange Book. So this is just a flag for that'll be relevant for all biologics. In terms of cost sharing and benefit design, so the literature often compares multiple GLP-1s, so this literature review will look familiar to you. Again, generally, as the copayment levels increase, the proportion of patients that get at least 80% of their days covered decreases, which it suggests that shows a correlation and suggests potential causation between costs and adherence. And then also, again, showing that it shows that higher income patients have better patients with lower out-of-pocket costs had better adherence than patients with a higher out-of-pocket costs. For the current or expected dollar value of the drug specific patient access programs, staff identified 2 specific programs for Trulicity. The first one is the Trulicity Savings Card, and the second one is Lilly Cares. And then we did get additional information submitted through the comment letter process and the public comment process, just providing some concrete numbers. One of the comments letters suggests that between January 23 to July 2025, about 14,000 Trulicity prescriptions filled in Maryland received Lilly-provided assistance, and about 83% of those claims reached an out-of-pocket cost between $25 and $30, with an out-of-pocket cost of $50 for at least 91% of claims. So that was provided through that, and we did update the dossier to reflect that information for your consideration. We have our average patient copay and other cost-sharing data for the state in factor 7.3. And then in 7.4, we provide the average cost share. And then finally, in 7.5, we include the mean, median, and 90th percentile of out-of-pocket costs for the different payer populations. Factor 7.6, similar literature to that was reviewed for the other GLP-1s. So again, we were not able to make any conclusive assessments based on our analysis of the all-payer claims database, but we did supplement with additional literature reviews as outlined below. In 7.7, the cost of the healthcare plans based on patient consistent with FDA labels and standard practice. So this is an amount that is provided to the board that verifies that the amounts that we're reviewing are consistent with FDA labeling or standard medical practice. And then again, in section 8, Trulicity received that same second comment request period. So we had our initial 60-day comment period that's available for all drugs that are selected for the cost review study process. For these drugs, we did open a second cost review study, or sorry, a second written comment request specifically targeting patients and clinicians with direct outreach to certain patient and clinician groups trying to get feedback. And then we did get comments on the dossier that was posted on August 20th. The staff did not identify any other regulatory or compliance issues that would provide additional context to the market related to this prescription drug product. And then also, the staff did not receive any input from state and local government entities for this specific cost review study. And then finally, here's our catch-all to basically say that all of the documents collected through the request for information were available to the board for their consideration. So with that, I'm happy to open it up for comment and question.
Wonderful. Thank you very much, Dr. York. Let's open it up for public comment before we go into, and I'll suggest anything that we have that we might want to include in the resolution, you can put forth now so that we can adopt before we go to closed session. That might make my process with the council a little more easier, whatever.
I have a comment and something that I wanted to propose for the affordability challenge component. So maybe I just start with the comment, which is also, in this case, great to hear that we had the multiple steps in terms of providing opportunity for public input, or patient and public input, I should say. I wonder if it's something that we shouldn't consider, is to seek input on our process as to why we're not hearing from interested parties as much as we would like in terms of users of these medications. Are there situations where a more confidential situation for them to provide comments would be more acceptable? Can we do that even? But I think just hearing from individuals, not in terms of seeking their input, but as far as seeking their feedback on our process, could be helpful, so that we're not continuing to offer second and third options and they're underutilized or undersubscribed. So that was for just thinking about patient and public input. For the affordability component, for Trulicity, I'm looking again at the utilization section where we have in tables 7A through 7D broken out the proportion of total gross spend by commercial, state and local government, Medicaid, and Medicare. And the numbers in that case ranged from 2.27 to 2.89. So in my view, with the state and local government at 2.27, that represents an affordability challenge.
Okay.
We're going to talk about this in the closed session as well, but if I look on table 19 and the Trulicity out-of-pocket costs for the commercial, they're anywhere from $200 to $4,000. For state and local governments, they're anywhere from $220 to $280, and for Medicare, they're anywhere from $39 to $1,400. So lots of variation here, but there's lots of out-of-pocket expenditures for people at the 90th percentile.
Okay. Anything else that we want to make a part of it? Any other question?
Yep.
And it doesn't affect any of the numbers, but do you know why? It seems like both of our drugs this morning had the shortage about the same time, and they came off about the same time. Is there was there a change with FDA or with the drug shortage list, or it just happened to be that way?
Yeah, so I think there's a couple things. The primary one is it would be related to the other drug that was reviewed, which is Ozempic, and this is a very well-publicized element, that there was extremely high demand for off-label use, and potentially on-label use too, patients with diabetes, but also qualified for obesity. But it basically became identified as a primary drug for weight loss and drove huge demand for that. to the point that the manufacturers had to basically scale up production capability. Also, just looking at the years, I think you can also look at potential supply chain issues related to the pandemic, maybe. That might show why they're both the same, because I don't think there was that same demand on Trulicity for weight loss. There was probably some, like I think GLP-1s as a whole were recognized as drugs that could be used for weight loss, so it may have been some capacity issue there. It's also, approved as a biologic, so there may be additional just manufacturing challenges with that. Staff can do additional research on that, though.
But it's not necessarily normal for a drug to be on a short list for 3 years.
No, that isn't
Right?
usual, yeah. And I think the GLP-1 case study it's a very unique one in that it had a very high demand off-label use that took a while to get production capacity to meet. But I think all manufacturers say that they have the production capacity now. Yep.
Great, thank you. Stephen?
Can I ask, do you know if all of these drugs are made in the United States, or are they made in China or Europe or somewhere where they may be subject to tariffs from this administration? The other question is how many have been made in Puerto Rico, which, yes, is not be subject to tariffs, but they've had destruction due to hurricanes and et cetera over the last few years?
It's a good question. It's something that should be publicly available. I don't have it off the top of my head, and maybe staff can see if we are allowed to provide that information. We may be able to track that down on something like the FDA website or the manufacturer's websites, so we can get back to you on that. I don't think we have direct manufacturer location. Yeah.
I mean, I don't want to put Darren on the spot, but from the industry's point of view, have the tariffs had an impact at this point, or no?
I think what you hear from all the companies, it's different for every company, and I can't speak
Right,
individually.
right.
In terms of supply chain, it really depends on what we're talking about. Are we talking about the raw materials to manufacture it, which tend to be from China and India? Or are we talking about where it's actually manufactured, which tends to be in Europe or the United States? So it's a very complex process.
Okay. Anybody got anything else? So, Michelle, do you want to recap, or do you want me to have Barry and Jerry recap there too? I think just two, right, that we're putting forward?
I understood it only to be one.
Oh, maybe I was wrong.
Dr. Anderson, were you making, I thought you were making an observation, but that you were not.
Observation that we will then use in the closed session.
Understood.
Okay.
So do we understand, Barry, that you were recommending that the board make a preliminary determination that use of Trulicity has created an affordability challenge for the state healthcare system, or an affordability challenge in the form of high out-of-pocket costs to patients, based on the circumstance that total gross spending for Trulicity for state and local governments exceeds 2.27% of gross prescription drug spend?
Yes. High affordability costs, high cost for the state and local government system.
Okay. And just so I'm clear, and the affordability challenge is to the state healthcare system, or in the form of high out, no, I guess it
To
would
the
be
state
health-
healthcare system.
Yep, okay.
Everybody clear on that?
Yes.
Now, would you like a motion on that?
Yes, please.
Okay, so we'll entertain a motion for that to be included in our resolution.
So moved.
Moved by Stephen, second by O'Barry. All those in favor, aye?
Aye.
Opposed? Thank you. Okay,
One other matter, Dr. York had requested a motion at the end of the presentation to include the 7 additional NDCs in the cost
NDCs.
review study.
okay. So moved by Jerry, seconded by Stephen. All those in favor, aye?
Aye.
Opposed? Thank you. Is there anything else, Dr. York, for this?
No, sir.
Okay, then I'll entertain one more motion to go into closed session to review and discuss proprietary and trade secret confidentiality information concerning Trulicity under General Provisions 3-305B13 and Health General 212C03 and 212C10.
So moved.
I second.
I believe there's a little more.
To receive legal advice, I was just testing counsel to see.
We go.
Right, I wanted to see if counsel was, to receive legal advice from counsel regarding the cost review study and maintain confidentiality and attorney-client privilege, I can't even say it, in closed session under General Provisions 3-305B7. Do we have a motion? Thank you, Barry. Second, Stephen. All those in favor, aye? Aye. Thank you. We will work and eat lunch at the same time, so we'll give you all plenty of time. Let's say we will come back at 1:30. That way, I think we'll be done. We can do the motion. So is that good with everybody out there? That gives you almost 45 minutes. Thank you. Okay, we are going to go back into our board meeting for open session. And I'm going to recognize counsel for the resolution to be read for the second drug, Trulicity, for the purposes of adoption.
Resolution 2024-04 of the Prescription Drug Affordability Board, preliminary determination cost review study of Trulicity, November 17th, 2025, whereas the Prescription Drug Affordability Board is authorized to conduct a cost review study of selected prescription drug products, and whereas the board selected Trulicity for study, and whereas the board has considered the data analyses and information assembled by staff in the dossier organized in part by regulatory factor, and whereas the board has considered the public oral and written comments received to date as part of the cost review process, and whereas the board considered, discussed, and deliberated concerning the proprietary, trade secret, and confidential information and data in closed session, and whereas the board may preliminarily determine whether use of the prescription drug product has led to an affordability challenge to the state healthcare system or high out-of-pocket costs for patients, and whereas the board may identify circumstances under which the prescription drug product has or will lead to an affordability challenge to the state healthcare system or high out-of-pocket costs to patients, and whereas upon consideration and deliberation of the proprietary, trade secret, and confidential information in closed session, the board voted to make a preliminary determination and identified one circumstance relying on confidential and proprietary data under which the prescription drug product has led to an affordability challenge. And whereas the board hereby ratifies the closed session vote determination and the identified circumstance as set forth below, along with the determination made in the open session, it is hereby resolved that the board makes a preliminary determination that use of Trulicity has created an affordability challenge for the state healthcare system and an affordability challenge in the form of high out-of-pocket cost to patients, and that the use creating the affordability challenge was consistent with the labeling approved by the FDA or standard, I have the correction, has created an affordability challenge for the state healthcare system and an, period, end of that phrase. The part about the high out-of-pocket cost for patients was not part of this analysis, and that the use creating the affordability challenge was consistent with the labeling approved by the FDA or standard medical practice. The circumstances under which the drug product has led to an affordability challenge include, 1, the percentage change in WAC over certain periods is substantially larger than the percentage change in inflation, the rate of increase in inflation, and that was done in closed session. And 2, total gross spending for Trulicity for state and local governments exceeds 2.27% of gross prescription drug spend for state and local governments in the public session. Be it further resolved that in accordance with COMAR 14010405F2, the board's preliminary determination is non-final and subject to revision and modification, and any circumstance is a sufficient and independent basis for the preliminary affordability challenge determination. Be it further resolved that the executive director and staff are authorized, directed, and empowered to draft a cost review study report in accordance with this resolution and the regulations to be published as a draft for public comment, subject to a final determination and approval of a final report. So submitted as corrected.
For adoption of the resolution.
So moved.
Second.
Moved, second by Stephen. Discussion? Any addition? Corrections? Hearing none. All those in favor, aye.
Aye.
Opposed? Unanimous. Thank you. Now, we're going to, because of the Trulicity work group we just had, we created new findings for ourselves that affect Ozempic. So we're going to amend the resolution that was adopted earlier to remove one of the items. Michelle, do you have anything else?
Based on the calculations, the board may wish to entertain a motion to amend Resolution 2025-03 by striking the 8th and 9th whereas paragraphs, which read, whereas upon consideration and deliberation of the proprietary, trade secret, and confidential information in closed session, the board voted to make a preliminary determination and identified one circumstance relying on confidential and proprietary data under which the prescription drug product has led to an affordability challenge. And whereas clause 9, whereas the board hereby ratifies the closed session vote determination and the identified circumstances as set forth below, along with the determination made in open session. And further strike and rescind the finding that Ozempic created an affordability challenge based on a circumstance that at the 90th percentile, patient out-of-pocket cost in state and local government markets is disproportionate to the net cost paid by payors, which was done in the closed session. That would mean that the sole remaining determination of an affordability challenge would be based on total gross spending for Ozempic for state and local governments exceeding 4.87% of gross prescription drug product for state and local governments, which was done in open session.
Motion for the adoption?
I move.
Moved by Barry, second.
Second.
Stephen? Any discussion? Everyone understood what we spoke to? All those in favor, aye?
Aye.
Aye.
Opposed? Thank you. And I'm glad we found that and recognized it when we did. Andy, why don't we do a couple quick things before while you're there. I think we were neglected to have you introduce our new staff. And I think before people leave the room, it'd be nice for you to do that.
Thank you. So we are excited to announce that we have our new quantitative health policy analyst working with us, Chidera Agwu. She's been with us for a few weeks now and really is getting thrown into the deep end with her work. So has already been a valuable member of the team and look forward to working with her. So.
Also, Dr. Georges Benjamin, who, as we announced, has been selected for the board, replaced Dr. Levy. Of course, had commitments for the first 2 months, and he will be at our December meeting on the phone. So he's still out of country or back and forth. So we look forward to Dr. Benjamin coming on board. And then I noticed we have I'm just trying to clean this up because at the end, I think we'll be ready to go. It shows our next board meeting is January 26th. We actually, remember, have a vote board meeting on call virtual on December the 8th at 9 a.m. So please make sure you're available for that. We have two main things. One is our extension of the lease that needs to be approved by the board, and the second is our study from the staff.
Yep,
right?
Annual report, yep.
Okay, with that, we are at the end, which is the public policy process for number 8, upper payment limits. We're going to take Farxiga and Jardiance separate, so you'll do Farxiga first, is that correct?
That's right.
Okay.
Yep.
The floor is yours.
In this afternoon session, we're going to work through the framework process for Farxiga and Jardiance. So just for everyone's reference, in our, September meeting, we went through potential policy solutions. So we worked through the drivers of the circumstances that the board identified, and then policy solutions that could potentially address those the drivers. So we had discussed a patient navigator program, delinking PBM reimbursement from rebates, and potentially an inflation penalty. Those are all non-UPL policies that don't require additional, that have, will be reconciled through a final step when the board approves the final cost review study process. Our upper payment limits have a much more structured process. So the board did indicate that they were interested in moving forward with understanding what an upper payment limit would look like. So they did want to move forward with the upper payment limit process. And the next step is for the staff to recommend a potential framework to the board for your direction. So that's what we're going to go through today. These are the regs, but just at a very high level, these are the considerations for the board, so the general guiding principles. First, they must consider the cost of administering the drug, and I will read through these just so you have them, but we'll move through it quickly moving forward. Cost of administering the drug to the consumer, as well as other relevant administrative costs. Determine whether the upper payment limit is an appropriate tool to address the drivers of the affordability challenge identified by the prescription drug product, and the board tentatively did that in the last meeting. Also confirm that setting an upper payment limit we'll make sure that they set an upper payment limit in a way to minimize adverse outcomes and minimize the risk of unintended consequences. And then also prioritize drugs that have a high proportion of out-of-pocket costs compared to the system net cost of the drug. This is an important part. The board shall not set an upper payment limit if the spending on the prescription drug product of the eligible governmental entity is less than the administrative cost to administer the upper payment limit. And then also that the prescription drug product is generic and there are 9 or more marketed therapeutic equivalents out there. And then finally, the board shall not set an upper payment limit that impacts statutory and regulatory amounts, such as the Medicaid best price, or is lower than the Medicare maximum fair price. That's an important element for the conversation today. Okay, so where we are in this process is we will recommend at least one framework for the use of developing the UPL. And we can also recommend contextual information identified throughout the different materials you've already received that you should account for in this process. At a very high level, the frameworks are the different ways we could go about calculating an upper payment limit amount. Our regulations articulate 7 plus a blending of them. And I think there's potentially more than that. But the staff goes through each of these different analyses to understand what the potential, upper payment limit rates could be, and then tries to make a recommendation based on those analyses. So in this presentation, you'll see in the framework document, we only included our recommendation, and not to beat the punchline, but it was going with domestic reference pricing. And one of the most accessible domestic reference prices is the maximum fair price, which, as we just talked about, was the floor that you can use based on our regulations that we've set for ourselves. But in this presentation, we also just wanted to show you the range of values that would be available to you if you were allowed to go below the maximum fair price. So we just wanted to make that information available to you. So at a high level, cost effectiveness uses cost effective analyses to model how much additional health outcomes is gained per dollar of additional spending when using a drug product compared to an alternative. And through this, we did a literature review that was included in Exhibit A. And it showed mixed results, but some literature supports the findings that the drug is cost effective at existing net prices. So staff did not come up with a specific number under a cost effectiveness analysis, but basically just stated that, under some of the results that were, some of the studies provided to us, it was cost effectiveness at current net prices. The next is what is therapy. We call this the therapeutic class reference pricing. So you'll remember that these are a drug class called SGLT2s. So we look across the SGLT2s to see if there's any way that we could benchmark certain drugs off of each other. And this was probably one of the more interesting analyses. We identified one drug in the class, Brenzavi, that is sold for $50 for a 30-day supply. This fits into the cash plus or direct consumer distribution network. So it doesn't have some of the features of the insured market. So that is something to note, that many insurers do not currently cover this drug, but if you're paying cash, you are paying a total of $50 compared to the different net prices that the board has seen for Farxiga and Jardiance. So this was an interesting finding in the analysis that we did. We also do a launch-based price upper payment limit, where we basically use the initial price at which the drug was marketed and adjust for inflation. You'll remember that one of the findings was that the list price was increasing faster than inflation. So we do have a launch-priced based UPL, however, did not provide savings compared to the net price, so we did not provide that as an option for the board. We also look at same molecule reference pricing. In this case, there is an authorized generic, and the NADAC of that authorized generic was a unit price of $11.47 for a full 30-day supply of $344.15. So again, no savings available off the net price, so that was not one that we recommended. Then we did a series of different domestic reference prices. So the board will remember that we can look at a number of different things, including the national actual acquisition costs. Oops. With the NADAC, there's a typo in that, I apologize, which was $559 per month and 1684, sorry, 18, sorry, I need to pull this up on my screen. Here, I'm gonna pull this up real quick. There we go. It's a 30-day supply of 100, oh, so sorry, for national actual drug acquisition cost, it is $559 and $18.46 at the unit level. For the state actual acquisition cost, it was $555, and I'll just stick with the monthly cost for all of these. And then the federal supply schedule was $452. And then there is a maximum fair price, Medicare maximum fair price for these drugs, which is $178.50. So you can see the difference there. Going to the next slide. We also, at this stage in the process, can look at international reference prices, almost to just give you a comparison for what the U.S. is paying compared to international entities. So you can see that in the United Kingdom, the 40-day supply or 30-day supply is about $42.37. Germany is about $84.22. France is about $42.46, and then Canada is about $52.50. These are all in US dollars, so we converted. Because these are all below the floor that you are allowed to consider, these are our general approximations based on publicly available international prices. I think if we ever did anything around international reference pricing, we have standardized data sources that we can use moving forward. So just wanted to flag that. Again, these are, so this is primarily just for the board's reference at this point. Going on to the budget-based impact. So given the longstanding use of this drug and the lack of a methodology for setting an appropriate budget, staff did not recommend using a budget-based impact model at this point. And then in terms of a blend of multiple frameworks, we do not recommend that for this drug because there is a clear methodology that meets the needs. So the staff's recommendation, oh, and then here's a summary of the frameworks. This is all just articulating what was all the different numbers that were in the presentation, and it gives the board a way to look across the numbers and just see the range of values that are provided for the drug, and we tried to put that into a bar graph as well. You can see that there are a number of drugs or reference prices or potential options that are below the floor that we've set with the maximum fair price. But since you're not allowed to go below that maximum fair price, we did not recommend those at this time. So the staff's recommendation is to use the calendar year 2026 negotiated maximum fair price for a 30-day supply of $178.50. And then we also have the unit cost of $585, sorry, of $595, excuse me. The data sources are the published Medicare maximum fair prices from the Centers for Medicare and Medicaid Services. And then the calculation is using the MFP as a price benchmark, and the board sets an upper payment limit that's no lower than the MFP. And the negotiated MFP is $178.50 for a 30-day supply, or $595 per unit, based on the FDA labeled unit of 1 pill per day.
So Andy, why would you use the maximum fair price as opposed to the state actual acquisition cost?
State actual acquisition cost would not have reduced the cost. So if you go into the table, you can see that the state actual acquisition cost is about $555.
Right.
And that represents what the pharmacies acquire the drug for. It's very comparable to something called NADAC, the National Drug Actual Drug Acquisition Cost.
Right.
So those two are comparable, but they're still pretty high and would not have major savings. Yeah. Okay. So I did want to go through the savings estimates. So we cite to a publicly available paper throughout our framework document, and I think it's also referenced here, that basically tries to estimate the savings of the Medicare maximum fair price compared to the estimated commercial average net cost. And this is all for Medicare, so that is an important consideration. So the paper basically estimates across all 10 negotiated drugs the potential savings, and we use those as a benchmark. And again, it's a document that's publicly available, so you can recreate those study findings if you have access to the different data points. And basically what it finds is that, so Medicare reports that the negotiated price is a 68% discount from the list price. And this produces an estimated savings, or an estimated $4,923,966, or $996 in reduced spending for state and local government based on the list price. So this doesn't reflect the rebates and discounts received, but it would reduce the gross spend seen by the state if it was applied on the front end. And then the study that I referenced found that the MFP for Farxiga may not, it basically estimates that the Medicare negotiated maximum fair price is approximately the average commercial net cost. So there may not be additional savings for entities that are paying the average commercial net price, but there will be savings for entities that are paying more than the average. So there is savings available, but it's not necessarily across the board. So I'm happy to kind of talk through those findings if that's helpful. And then going on to the contextual information, we have a series of things that we're allowed to consider, and we articulate the ones that we want to be able to consider when we're doing this work. One is the information gathered during the cost review study process and the policy review process. The other is the net costs for state health plans, state and local government health plans, direct government purchases, and Medicaid. Also the average coverage status in state health plan, state and local government health plans basically, and Medicaid. And then also the utilization of those programs by patients and prescriptions, and that's the state health plans, state and local government health plans, as well as Medicaid. And then the amount of direct government purchases by the units and patients served, and then the budget impact analysis. So all of those will be available to the staff for consideration. We did receive public comments, so we posted the framework on November 4th, and the board has received a number of public comments. I think just to summarize at a very high level, some entities, we did get a lot of support for moving forward with an upper payment limit, so I should start with that. Multiple entities supported moving forward with setting an upper payment limit. For the entities that did not support moving forward with it, some of the key considerations were that the maximum fair price is specific to the Medicaid market, that there's certain dynamics that we should consider about the Medicaid market and the Medicare, I meant to say Medicare for all of those, the Medicare plan design that fed into those negotiations. So I think that's just something to consider, is that the commercial market and state employee health plan market doesn't have the same plan design or restrictions that Medicare does. So that's just one thing to consider. Yeah, so I think at a very high level. And then there were, I think there were the same general feedback that we hear on upper payment limits in terms of considerations on access, ensuring access, and minimizing unintended consequences. So with that, staff recommends the framework of domestic reference pricing using the Medicare maximum fair price. And we recommend being able to consider the contextual information in 1, 2, 4, 6, and 8 are articulated above. So what we're looking for from the board is direction on whether or not you would like us to move forward with a methodology document that would actually kind of flesh out the final recommendation. Again, the final step for the board is to approve the UPL in a subsequent step. But this would allow us to move forward and get the additional information, continue to do additional analysis if helpful.
Of course. At the chair's discretion, I'm going to, what I'd like to do, if the board is okay with it, is I'd like to have them ask questions of you of Jardiance now.
Yep.
We'll dispense and then have you do, with Farziga now, and then we'll do Jardiance, and then I'll take a vote on both of them at the end. Is that okay? Sure. Okay, so let's open the questions up now for Farziga, just for that you might have of Andy or staff, and then we will stop and then take up Jardiance, and then at the end, we'll do a vote on each one as to your direction to the staff. So any questions on Farziga? Jerry?
Just so I can be clear, this is really about the savings estimates that you do. First of all, it's clear to me that CMS believes even on the Medicare program that they actually had savings. So, whether or not that applies to Medicaid and the states, but CMS at least believe for Medicare that it did generate savings, correct?
These are negotiated prices, yes, these are the results of their negotiations.
Right, and
Yeah.
so they wouldn't have, they expected to get savings out of their negotiation. The second thing is,
I'm not sure the answer.
I think it's a technical response. I think that they were going through the process to negotiate prices. There is a kind of specified framework that would set, but I think that your characterization is generally correct, yes. So.
yeah, so, and they wrote a report at the end saying that they had generated savings.
Yes, across the book of negotiated drugs, there were substantial
Correct.
savings, yes.
Number two, the state has many different components. So what might be substantial savings for one component might be minimal savings or no savings for another component. So we know, for example, that prisons have a much higher, typically pay a higher rate than some other components of it. So even though the commercial rates might not show substantial savings, significant components in the state might show savings.
Correct, yes.
Whoa. When you say that the prisons, are you talking about the employees or retirees?
No, I'm talking about the prisons themselves.
They fit within our, they can be for direct purchases, so.
The people the incarcerated people.
Okay.
And they're
But not the employees or the retirees?
Well, it could be that too, but what we know from studies is that incarcerated services tend to be, the drug prices tend to be very high for that. So what I'm making the point is, it's not, you get a commercial rate and you save a little bit, but there might be parts of the state that are saving a lot and other parts of the state that might be saving less.
Is that a question, or do you?
No, we know that there is significant, I'll ask Andy, but we know that there is significant variation within the state in terms of how much they pay.
Those are all true statements, that there is a range that folks are paying. The MFP likely represents an average. So there are people that are paying more. There are certainly parts of the state that are paying more. There are likely parts of the state that are paying less. So some parts of the state can find savings and some may not.
So when you get all payer claims data
Yeah.
for state,
But this
is it an average?
So I'm not sure. So the all payer claims database is gross spend, and it's not an average.
From a state budget, I don't want to argue, but from a state budgetary standpoint, I've never seen that broken out. I mean, we get raw numbers on the individual agencies' budgets.
Right.
And from a healthcare perspective, at least in the health department that had the hospitals and the clinics, I never saw it broken out like that. It was always that, it was the total cost or averages.
correct. Well, I mean, that's what I think Andy could do in his report for the next, 2 months. But I think I would allege or assume that there is significant variation within the state in the amount that they pay for Jardiance or Fartsiga. And, we could take a look at that. And so that there will be, I assert that there will be savings for some components of the state, even if the overall amount is not there for some.
On the flip side of that, will there be any components that might wind up paying more? Since we're talking about averages, and we're setting something.
This is an upper payment limit, not a payment limit. So this is the most that they can pay.
Right.
Right, so to his point, if
Will, if there are some that are actually lower than that now, are they gonna wind up paying more money?
No, I would say because it's an upper payment limit, you can't pay more than you, if you were less, then you'd pay less. So if they're only paying $100 and we set it at $105, they're still gonna pay $100.
But if somebody was paying 15, they could increase it to 25.
They could increase it to 25.
That's Stephen's point. That's the offset. So if the pot of money is $1 million to the state, as long as they get $1 million, they don't care. We haven't done anything. If you set the upper payment limit at $1 million.
For a particular drug.
Right, and they get it from multiple entities, to your point, and they change the average, and they still get $1 million, they don't care. We haven't reduced the spend to the state.
We have.
I would
It's
think
just
we have.
Some were paying a lot less, some were paying a little bit less, and maybe some were paying a little bit more.
I'm thinking from the state's perspective.
Yeah.
And
Total on
I
the
think-
state, yes.
But if you're the prisons, you care.
But yeah, but he's talking about a particular, individual units.
But if I'm appropriations chair, setting the budget, it's the total.
Right.
It has nothing to do with one entity.
And
I
have
can-
we seen data on this? I mean, because I hear what you're saying.
Yes.
Yep.
The question is the ask then to go collect more data?
Correct.
To determine whether there is variation?
Right. I would think that they're going to find savings.
And I could try to address, I think what you've identified is some of the complexities that we're trying to address. So to the chair's point, like right now, I think our goal is to actually reduce that overall budget. So if the state budget is $300 million for the state employee health plan, we wanted to go down to 297 by addressing specific line items. I'm just showing you the math. Yeah. Yeah. But I think that's how this would work, is it's specific.
If you're the governor, you only care about one thing.
Right.
I
And
think is my deficit a
the way we
billion or 2 billion?
proposed it would work, that's the intention, is to actually reduce the cost, the overall budget, by reducing specific line items. But then I think what you've flagged is that that's not necessarily how these contracts are articulated. Like even on the plan side, it's negotiated on a book of business. So then turning the dial on a specific line item to adjust the overall budget, there is a lot of opportunity to kind of move numbers around. So I think that's one thing that the board just needs to protect against as you work through these. So when you're turning the dial on a specific line item, you want it to apply to that line item and then not flow somewhere else, basically.
Oh, absolutely correct. But I think, they are separate components in the state budget. And, I think we've got to look at that. And also for Montgomery County versus Calvert County, all of them have unique prices, and some of them might be paying less than the upper payment limit, and some of them might be paying more. And I think we would protect the ones that are paying more at the county level, or for the prisons, or for other components that it's under our jurisdiction.
Correct. Yes.
Yeah, so then the data that would really help me, which you're not going to like, would be the data of what you come forward with an upper payment limit number.
Yep.
How many are above and how many are below?
And that's something we've tried to get access to, and what we've found, so we've had luck with some of our state and local government partners, but the way that the contracts currently work is that even if a state tries to figure out, if they walked, in this case, Farsiga, if they went to their PBM and said, hey, how much am I paying for Farsiga at the end of the day? PBM says, we can't tell you. So when we go to our state partners, they are getting a response that is, we can't tell you. Now, we have ideas on how to try to get that information moving forward, and I think once the rubber hits the road of we're actually implementing it, at some point we would have to have that conversation. But how much we'll be able to identify that at the front end, we're working on that now, but don't currently have those answers, and unclear if that will be available in the foreseeable future without additional authority to collect this confidential proprietary information, so.
Okay,
Let me try a third argument here.
discussion.
Discussion. Savings in the future. So we set UPLs for today, but until we modify them, they remain in place, correct?
Correct.
And in most cases, prices go up. Not all, but in most cases go up. So we would save money in the future for this.
It sets a ceiling that protects the state from future price increases, that's correct.
And finally, the numbers that you're giving are estimates
Yes.
of savings. And there are other people that have done savings estimates which are different than the ones that you have presented, correct?
We would welcome any other estimates that we could use. We thought we did a pretty good literature review, and we did our own calculations based on SSR.
So Aaron Kasselheim has done something that you should take a look at, that they
We've been having
published in
trouble
the
finding
New-
it for these specific drugs. So we see a lot of estimates at the program level. It's the specific drugs that are the challenge, so.
But these were drugs that were negotiated by CMS.
Correct.
And so he did a report on those 10 drugs.
Okay, I'll take a look at it and see what they're saying.
So, there are different estimates of terms of it. And it's also about commercial insurers, which could be higher and could be lower.
I think that's correct. Yeah, that's the biggest point is, go ahead. There are certainly people that are paying more, and there are people that are paying less, yes.
Just to Jerry's third point on discussion, just for the general public, and maybe you can clarify. When the board, if they do, sets an upper payment limit, what Jerry just said to me assumes that the price is that price indefinite in the future.
The upper payment limit
Until we
one?
change it.
Correct, that's
So
currently.
does that take any assumption about a cost of living increase or anything? And
That's
if
a good
so, how much?
question. I think I would picture it to be an annual process. Michelle, do you?
I would say we haven't gotten that far yet, right? I mean, so that's something the board can consider
Well, I
in,
mean,
in how they're
he
structuring
made
it.
that statement publicly, and I know there's people not here, and I wanted to just clarify and make sure that, like, are there cost of living increases? And is
So
this
right
set for
now,
20
I mean,
years, or-
you haven't set any parameters. So right now, there's nothing.
Correct.
Right? So that is something that could be included. There are certain triggers which would require the board to temporarily freeze or suspend the UPL and,
Shortages
do
and
another
stuff like that,
analyses, et cetera,
Right.
right?
Right.
But that is all something that could be included or developed, or, you can think prospectively whether you want to have a process.
No, and that's fine.
but-
And I'm not
yes,
being
add-
argumentative with Jerry, but I just wanted, the way it kind of came off, if I was out there in space,
Right.
I would go, oh, it's a fixed price and it's that way forever.
Yeah.
With no changes or cost increases or whatever. And I think that might not be 100% accurate. That's all I'm saying.
I think it's true that once you implement the upper payment limit, that structure that you've put into place exists until you change it. But to council's point, you could bake something in that says we want
Right.
to increase by inflation or
Right.
something,
Right.
medical inflation
Right.
or
I would
CPIU or
have
something.
no problem with that.
Yeah. No, that's, I was just,
Yep.
more for, I think,
Yes.
the general person out there listening.
Yeah.
Okay. Jerry, anything else?
A point of clarification for me would be where you talked about the recommended contextual information and you listed, it had 1, 2, 4, 6, and 8.
Yeah.
Is that, so,
We did it by citing to the regulations. So the regulations basically just have a list of all the different contextual information we can include. So we just picked the ones, these are the list of contextual information that we want to be able to consider.
okay, but
Per the
as far as what
regulations.
I can see on the slide here, left out utilization information, which is 5. Was that intentional or?
It might be based on the market
Or
segment.
is because
I'm pulling
the
up the regs
measure
right now,
was
I'm sorry.
big? I just wanted to double check.
In bullet 6 or 5 there, I can't see that far over, right? So it's 1, 2, 4. I can't see if
So-
that's 5 or 6.
Yeah, 5 is left out, 6 and 8 are included. I just didn't know if that was intentional or.
I'm checking.
Well, utilization
used
is on the
utilization
slide.
Before,
Yeah, utilization is on the slide
okay,
in the following programs by patients and prescription.
agreed. It's just the 2 slides down left it out, so it's just a
Oh,
bit of
thank you.
inconsistency.
Oh,
She's just asking for clarification.
yes, this
I didn't know
slide
which
is
slide was
correct.
Right.
Yes, so if I misstated those on the
Okay,
final
great.
slide,
No
I can edit
problem.
those right
We just
now.
have to, no problem. I want to make sure to include utilization information. right,
Yes, thank
visibility.
you, I'm sorry about that.
Key.
Okay.
Does everybody understand that?
That's a good
Everybody okay
catch.
with that? Clear?
Yes.
Okay. Stephen, you have anything on? We're clear. All right, Farsiga. Okay, we're going to pause with Farsiga before we vote. We're going to take up Jardiance. And Andy, just, I'm not admonishing you. I'm just saying, I'm sure you have 20 slides with this as well, but we got these and we've had them.
Yep.
The board, the public, everybody. Can you just just highlight some of them and just clean it up so we can move forward here?
Okay, so just flagging, okay, so we're now going through Jardiance. So we already just went through the principles. Again, the key is the maximum fair price is, you can't set a MFP that's lower than the maximum fair price. So staff generally did not do a deep analysis as soon as we understood that it was going to be below the maximum fair price. Again, no substantive options on cost effectiveness. Same thing, we have that same therapeutic class alternative, Brenzavi, for $50 a month, which I think sets an important benchmark. Launch price didn't provide any savings. Same molecule, there were no qualifying molecules for reference. You can see, again, there is the maximum fair price for $197, but all the other prices were pretty close to what's currently being paid, so there are no savings there. These international prices are a useful reference point for you, but again, below the maximum fair price, so below the floor that you're allowed to consider. Budget-based impact, again, wasn't recommended for this drug, and then no recommended frameworks. Here's all those available in a table for you, just so you can look across them for comparison's sake. Here's the table. Again, you can see here's the maximum fair price, and there's a number of available reference points below that, but the lowest you're allowed to go per our regulations is the maximum fair price. So again, just same statement, staff is recommending using the Medicare maximum fair price as your reference point for $197 per month, or unit cost of $6.57, if my eyes are not deceiving me. And then the savings estimate is similar, but there was one important distinction is that the paper that we referenced, and again, we can go back and look for more studies. This was the one that was at the drug level that we found to be most useful. But basically, the paper found that the maximum fair price was a 63% discount. Oh, sorry, the estimated average current rebates for Medicare, this is per the paper, were estimated to be at 63%, and that the discount for the maximum fair price was 66. So there is this 3% of available savings in addition to what the average price is. So those same savings that you would see from Farxiga, you would see those for Jardiance, plus the average is about 3% lower. If that's the correct way to characterize that. So our estimates are that it could yield about $300,000 savings across the state if everyone is paying the average. And again, we expect more folks to be we expect some folks are paying above the average, so there may be additional savings from there. Same contextual information. I do want to make sure that this final slide may not be correct, so I do want to make sure I account for that. But this is the contextual information that staff recommends collecting. So this is 1, 2, 4, sorry.
1, 2, 4, 5, 6, and 8.
Thank you. 1, 2, 4, 5, 6, and 8.
Two slides down. that's
Yeah, so
incorrect.
I just want to make
This
sure that we
one's
have those numbers recorded because that's what we're, 1, 2, 4, 6, and 8. So maybe it was just the Farsiga one that was incorrect.
Right here.
Sorry.
Consider this as a recommendation as being amended with 5.
Oh, thank you. So with that, staff is recommending moving forward with the domestic reference pricing, maximum fair price, and then also the amended contextual information as cited in the slide above.
I like that. Good speed. Good job. Very good. Okay. We're going to now go back and take up Farsiga for a vote. Wait a minute.
have questions.
Well, we do either way. Go ahead.
Okay, just more an observation than the question, but so as I look across the different payment limit frameworks, UPL frameworks, just kind of in this list of what you had on your framework slide, Andy, 1 through 8, from the cost effectiveness analysis down to the blend of multiple frameworks. There are a couple of them that I feel that we applied but didn't sort of apply if you were to do it prospectively and kind of to our use case, we did not apply. So, and that's fine. It's really neither here nor there, just sort of keeping it in mind maybe for the future. So domestic reference, international reference, you can go out and get the drug level information and get something highly specific to our use case, as with many others. But 1 and 7, we're going by the literature. These are not design studies for our use case. We're lucky if we find something that's at the drug level, whatever, or real world data. So I just want to put that point out there that it is still a point for us to hope that we get better studies that are tailored, whether it's to Maryland or even to the populations that are characteristic of what we're looking at for diabetes and comorbidity and what have you. And that may be just, again, something as the literature evolves, then we can do a better job applying a UPL framework based on those kinds of designs. But to use the literature is the best we can do, but I wouldn't consider that to be the way we would have done it if we're using these frameworks.
That's helpful. So I think we can do a spot check. Like we can put in parameters that match the state and do a spot check on the cost effectiveness. And I think I don't want to say I don't want to mischaracterize the analysis that we've done, but we basically found that like the value would not achieve savings if you put those parameters in based on, like, at a very high level, these drugs are cost effective at their net price. But I'm hearing you say you want to be that based on Maryland information, not the literature. Yeah.
Well, we found mixed results with the CEA studies.
Yes,
and
yes.
there's heterogeneity in those studies. So
Yes.
they weren't designed for our use case.
Yes.
And so I feel like, again, they're valid studies, their
Yeah.
methodology rigorous and fine for the purpose that the authors intended.
Yep.
But for our decision-making, if we're doing this prospectively, would we have done those 8 different studies 8 different
Yeah,
ways,
I
if you
see.
will?
Yep.
So, and then ended up with sort of highly variable results and very limited guidance, if you will. And so I think NA is appropriate in your table.
Yeah.
This is more just, again, this is a point that as we go forward, that's something I'd be looking for from the field is studies that are designed for the questions in front of bodies like this, to be able to develop more tailored guidance.
Yeah, it's a useful comment. I think staff kind of also expect, we would certainly flesh something like that out in the next step, which is our methodology. This first step is kind of to be the spot check to identify the appropriate tool. So like one of the spot checks is if you know, I think point well taken on applying, doing modeling specific to Maryland. I think there's some front end work that we could do there. But I think a lot of the working through the modeling and choosing parameters and assumptions and stuff like that, we would picture to happen in the next step. So I think staff will look for something that's, yeah, we can do quickly on the front end, yes.
Okay. Anything else? Do you want, or should I have, and I want this to be brief if anybody wants to say anything, but do you want to say exactly like what this board is getting ready to do to move forward or not move forward? And briefly.
Yes,
I mean, I understand it, but I want to make sure everyone here understands what we're doing.
Yes. I will just very briefly give context. So we are looking for direction on if the board wants us to move to the next step, which is publishing a methodology, which would get public comment. And then the board would then approve at the final step to move forward with upper payment limits with all the parameters in the methodology document. So we are recommending that you move forward with that at this maximum fair price and look for direction on that.
Okay.
Both on the using the framework that we recommend, which is domestic maximum reference pricing for the Medicare negotiated maximum fair price, and then also the contextual information that we outlined in the slide, not the final slide, the actual slide with the document.
Okay. Yep. Everybody understand that? All right. I entertain a motion in regards to moving forward for the staff recommendations on the framework of Farsiga.
So moved?
Moved. Is there a second? Second. Discussion. All those in favor, aye?
Aye.
Opposed? Aye. So 3-4, 1 against.
This is board instructing staff as to what framework to use and what contextual information to use.
Just what Andy stipulated.
Just adopting the recommendations of staff.
Correct.
Thank you.
Okay. So you'll move forward with Farsiga. And the second one is Jardiance. Is there any questions? Are there any questions? If not, I'll entertain a motion.
So moved?
So moved. Second.
Second.
All those in favor?
Aye.
Aye. Opposed? 4-0. Okay. Administrative updates, I think we covered most everything. Do you have anything else that we?
Only update is the board meeting that you had mentioned on December 8th, and then we have a stakeholder council meeting on December 15th, I believe. The agenda hasn't been published, but based on what we did for Jardiance of Farsiga, I would expect that to be their input on the drivers to the circumstances that the board just identified, and then also potential policy solutions for that.
Okay. Is there anything from Michelle? Christina, you have anything on stakeholder council, anything additional? How about openings? Are you in good shape on appointments now?
Yes, we're in pretty good shape. We still have a few vacancies we're working, or there's no vacancies. We're trying to fill positions that have expired.
Okay. And we have our delegate in the House. I don't know if Delegate Cullison would like to say a few words before we close out? Awful quiet back there. All right, I'll go around the table. Stephen, you have anything?
No, I think we got a lot of things done today.
Barry?
Nothing for me. Thank you.
Jerry?
So I think what we should start thinking about is the next generation of drugs that we're going to focus on. And so I don't know if it's January or some later date, but I think we have, these 4 that we've talked about. We have 2 more sort of in the pipeline, but I think we now have learned a lot over the past year and should think very carefully about which ones for the next generation we should pay attention to.
Yeah, I mean, I think that's great. I would just pause a little bit. The staff right now, finally, we're up to speed staff-wise, except for one person administratively. Hopefully, we get that person on board the next 30 days, maybe. Staff, as of today's actions, has an awful lot to do. I mean, I hear what you're saying.
I wasn't saying necessarily January.
No, but I'm just saying that I think it would be nice for this board and for staff to kind of, what I call clear the air on these first 4 in the processes and everything in the first quarter possibly. But it's up to the board if you want to, I just think that we are a little bit limited, and you can see how much time it's taking. So I'd just be conscious of that. We've got the legislature coming up. We have a couple things of interest that we're going to probably put forward and work with the delegations on. Hopefully Delegate Cullison will help us with. I'm sure they will have some things like PBMs and other things that'll be coming forward that they'll want our input. So we have to be conscious of Andy and Christina's time that starts to get split come January. So I just think we have to be conscious of everybody's time, that's all. Okay, if nothing else, I do thank everyone for their time today. I know it was a long day, but I think it was what we needed to do to kind of set the deck for January 1 and clear the air for the end of the year. Thank staff and appreciate everything that everyone's done. And it's nice to see everyone in person and be back in person. So with that, I'll move for adjournment.
I just have a question, Andy.
Yep.
Do we have to give a report to the legislature before December?
That's what's going to be approved at the Monday, December 8th.
Okay, yeah. 'cause
We
I'd
should
like to
be
able to-
publishing a draft
Yeah,
for
get it.
public
So you
review
draft
very
it back
shortly,
before
yeah, and then
send it.
December 8th, yep.
And the January meeting is remote.
January meeting has not been determined,
Oh,
correct? It is session. We'll probably be remote, yeah,
figured.
because they don't want to give us a room, which is smart. I mean, they don't want us here. I mean, if Delegate Cullison could, get us a room, maybe we'd be here. All right, with that,
Entertain a motion.
are we okay for move for adjournment?
So moved.
Thank you all very much, and have a good Thanksgiving.